So when I was following up my psych patients, I found that there were 6 useful questions that you could ask basically at any time. Number 1 is, are you sleeping well? Are you eating well? Are you having any auditory hallucinations, any visual hallucinations? And then are you having any suicidal ideation or homicidal ideation? So these are 6 good questions that you can ask at any time to your follow-up psych patients. Now, a couple of notes for this rotation. The physical exam for psych patients is the mental status exam. You don't take your stethoscope in, you don't do a physical, you do the mental status exam. And there's 6 components of the mental status exam. There's appearance, behavior, speech, mood, affect, and thought. And these can be remembered with the acronym ABSMAT. And then collateral is everything on this rotation. So you're going to be calling your patients' families and their friends and their roommates to really figure out what the true story is. And that's going to be a huge part of this rotation. So let's go a little bit more into the mental status exam. First, you have appearance. So what are some of the things that you can say for the patient's appearance? You can say, oh, maybe they're well-groomed, they're disheveled, malodorous, dressed flamboyantly. Do they appear as their stated age, or do they appear older than stated age, which is common in a lot of psych patients? For their behavior, this is stuff like, are they cooperating with you, or are they not cooperating? Are they guarded? How's their eye contact? Are they really slow? Are they really fast, having a lot of excess activity or tremors? And are they responding to internal stimuli? Like when they're talking to you, they're randomly looking off in the distance. And for speech, is it pressured, loud, soft, slow, or interruptible? For the mood, this is how the patient says they feel. And then for affect, this is how their emotional state appears to you. So are they feeling normal? Do they look sad, happy? Do they look like they have a flat affect? Things like that. Thought processes, do they have a logical thought process that's linear and future-oriented, or are they circumstantial, tangential, with flight of ideas, and with thought blocking? And for their thought content, this is assessing if they have any delusions, hallucinations, or suicidal ideation or homicidal ideation. The mnemonic for assessing depression is SIG-E-CAPS, and the mnemonic for assessing bipolar disorder is DIG-FAST. So this is sleep, interest, guilt, energy, concentration, appetite, psychomotor slowing, and suicidal ideation. And for bipolar disorder, it's distractibility, indiscretion, grandiosity, flight of ideas, increased activities, decreased need for sleep, and talkativeness. So what is the duration required for the diagnosis of major depressive disorder? It's 2 weeks, so it's pretty short where you can officially diagnose somebody with major depressive disorder. What is the most effective mood stabilizer for bipolar disorder? That would be lithium. 2 drug classes that you should be aware of that can increase lithium levels. That would be NSAIDs and thiazide diuretics. So you have to be very careful in patients who are taking these medications because the therapeutic index for lithium is very, very narrow. If a patient is taking lithium and they're now having a lot of fatigue, they're gaining like 20 pounds, they're having constipation, what is that caused by? That is lithium-induced hypothyroidism, which is a common side effect of lithium that you should be aware of. And what is the most effective atypical or second-generation antipsychotic? That would be clozapine. But what are some of the associated side effects of this medication? That would be agranulocytosis and cardiac arrhythmias. So typically, clozapine is not really used until you get to really late-stage refractory psychosis, and they need really frequent lab monitoring, and it's just a very difficult drug in general, but it is the most effective one. Duration that an SSRI or SNRI should be trialed before you assume failure. So this is if you have somebody who comes in who's depressed and they've been trying it for a couple weeks, but they haven't felt anything yet. Well, first you want to try it for 6 weeks total before you say that, oh, they failed this regimen. Patient with splitting, intense, and unstable relationships and self-harm. That's borderline personality disorder. And then patient with excessive emotionality, attention-seeking, and seductive and provocative behavior. That is histrionic personality disorder. These two, I feel like I remember I would get wrong. I would kind of confuse all the time. But borderline is really going to be the people who are cutting themselves, angry at people. And then histrionic is really going to be the people who are super flowery and flamboyant and like trying to have sex with everybody. What is the best treatment for borderline personality disorder? That would be dialectical behavioral therapy. And this is an important one because I actually definitely did come across this quite a bit while I was on my psych rotation. What is a screening test for major depressive disorders? So say somebody comes into your office and you want to see if they're at risk for MDD. This would be the PHQ-2. So this is what the PHQ-2 looks like. If they have a score greater than 3, that suggests symptoms of depression and requires further screening. And usually you do the PHQ-9 after that. You're going to run across this a lot in your family medicine rotation, your internal medicine, outpatient rotations. And this questionnaire is really, really frequently used. Number of symptoms needed in SIGI caps in order to diagnose major depressive disorder. You need 5+ of SIGI caps. So you do need quite a few. And this is actually really important for your shelves because a lot of times they'll say the patient hasn't been sleeping well, they've lost interest in things, they feel guilty about some things, but their energy is normal, they're concentrating fine, their appetite is fine, blah, blah, blah. This is all fine. Then that's not enough to diagnose major depressive disorder. They had to give you 5 of them on your shelf exam in order to diagnose major depressive disorder. And then do safety contracts actually reduce suicide risk? So this is like when somebody comes in, you have them sign this contract that says they're not going to commit suicide, basically. It's a really, really common practice in the hospitals. But unfortunately, there haven't been really any good studies that have showed good evidence for reducing suicide risk. And finally, I found this nice graphic on the Google Images, which kind of shows the progression of schizoid symptoms to schizophrenia and etc. So basically, what it says is increasing number of letters means there's increasing symptoms. So schizoid, they're very introverted and kind of like hermits. They like to withdraw from social interactions. Once they get to schizotypal, they start having the magical thinking and odd behavior. Schizophrenia is schizotypal plus psychosis. And schizoaffective is basically just a worse version of schizophrenia where they have schizophrenia and they have a mood disorder. And what you see in these patients, especially on your shelf exams, is that these patients will have mood episodes plus psychosis. And then even when they are not in a mood episode, they still have psychosis even in that situation. So this differentiates it from major depressive disorder with psychotic features, because major depressive disorder with psychotic features only occurs during the mood episode, whereas in schizoaffective, they're not going to be in a mood episode and they still have psychotic symptoms. What is the treatment for severe refractory depression? That would be electroconvulsive therapy. Are auditory or visual hallucinations more common in psychosis? That would be auditory hallucinations. And the way I was taught it is that actually if somebody was telling you they had visual hallucinations but no auditory hallucinations, you should be a little bit more suspicious that they might be lying to you. But I actually looked into it a little bit more and it looks like you can have isolated visual hallucinations. But again, auditory is definitely a lot more common than the visual hallucinations in a patient with schizophrenia, for example. What is the difference between a hallucination and an illusion? So a hallucination is something that's completely fabricated and there's no sensory input that's causing that hallucination. Whereas an illusion is an inaccurate perception of a real stimulus. So there is a sound that's playing, for example, but they perceive it as something else. For example, maybe the heater is running and they can hear that, but to them it sounds like voices, even though it's just the heater. Should psychotic patients be treated with SSRIs? Generally not, due to the risk of causing psychosis. So there are some situations where you would, but you definitely want to be a little bit more careful with SSRIs in patients with a history of psychosis because it can precipitate psychosis. What's a good antidepressive for depression in an old, fat, and slow person? This would be bupropion, and this is something that came up on my rotation, so I thought I'd throw it in here. What are the advantages and disadvantages of the above medication? So the advantages are you have no sexual dysfunction and no weight gain. The disadvantages are it's more activating, so you don't want to give this to somebody who has anxiety, and there is a lowered seizure threshold. So these are all the reasons why you would give it to a fat person, because obviously if you have bulimia or low body rate, it increases the seizure threshold, and why you give it to a slow person because it's more activating and you're not as worried about causing anxiety in somebody who's already kind of slow at baseline. First line treatment for bulimia, that would be an SSRI. What is the acute treatment of panic disorder? That would be a benzodiazepine, but long term, it would still be an SSRI. What is the first line treatment for generalized anxiety disorder? That would be an SSRI. And what is the difference between bulimia and anorexia? So this is a big one. I think when you're growing up, you kind of think of bulimia as the one where they cause themselves to vomit, and anorexia is just the one where they're self-restricting. But you can have different types of anorexia where it's they're restrictive eating or they're binging and purging. So really, it's not to do with like how they're limiting their food intake, but really it has to do with their weight. So patients with bulimia have normal weight, and people with anorexia are underweight. So you could have somebody who's binging and purging and their BMI is 25, then they would have bulimia. But if their BMI is 16, then they have anorexia. What is a reason that SSRIs should be used with caution in young adults? There is some evidence that there is an increased rate of suicide in young adults with SSRIs. But in general, this is a low risk and should not really preclude you from treating somebody with an SSRI because of how much damage there is just from having chronic depression. It's so much better to treat it and accept this slight increased risk. What is it if a patient has distressing mental images of stabbing her mother and counts down from 5 to 1 several times in order to eliminate these thoughts? This would be obsessive compulsive disorder, and this was a UWorld question that I had at one point. And which condition, obsessive compulsive disorder versus obsessive compulsive personality disorder, is egosyntonic versus ego dystonic? So this means it's kind of in line with their personality versus they feel like it's distressing and not part of who they are. So OCD is ego dystonic and OCPD is egosyntonic. So OCPD is really the like perfectionist type of people and the type A personalities that you'll often see. What is a side effect of abruptly discontinuing an SSRI? You may get a flu-like syndrome with like nausea, vomiting, diarrhea, stuff like that. Findings of serotonin syndrome, that would be hypertension, hyperthermia, and hyperreflexia. What is a reversal agent for serotonin syndrome? That would be cyproheptadine. What is a treatment for a patient with major depressive disorder with psychotic features? The answer is an SSRI plus an antipsychotic or electroconvulsive therapy if those are not working. Cigarette smoking can decrease the level of what two atypical antipsychotics? That would be clozapine and olanzapine, otherwise known as Zyprexa. So if you have somebody who's on your inpatient unit, they're psychotic, you give them Zyprexa, and they're getting so much better. And then you discharge them and they start going home and they start getting psychotic again, but they're still taking their medicine. One of the reasons is that they might have been smoking cigarettes and decreasing the therapeutic levels of their olanzapine. What is a demographic that is at increased risk for acute dystonia from antipsychotics? That would be young males. And what are some atypical antipsychotics with a lower chance of weight gain? That would be aripiprazole or Abilify, and ziprasidone or Geodon. And I'm going to go over a little bit more about the different classes of antipsychotics in just a little bit. What is a black box warning for antipsychotics in elderly patients with psychosis? This would be increased all-cause mortality. And this is something that's important to note because a lot of patients in the hospital will become agitated or they'll get delirious, and we will give them an antipsychotic to help calm them down, but there is an increased association with all-cause mortality, so you have to be definitely aware of that. First-line treatment for a delirious patient, that would be number 1, reorientation. And this is several times I've just gone to a patient's room and I've just been able to reorient them, have their family members nearby, and avoid having to give them a basically chemical restraint, which would be an antipsychotic. But the next step would then be an antipsychotic, usually olanzapine or quetiapine. And it would not be a benzodiazepine, which actually worsens agitation and delirium. So don't give Ativan to agitated patients in general. What is the difference between delirium and dementia? This is something you'll probably be asked on your rotation. And delirium is an acute altered level of consciousness, whereas dementia is chronic. So that's how you differentiate the two of those. What is the atypical antipsychotic with the highest risk of hyperprolactinemia? That would be risperidone or Risperdal, also known as, some people call it, Haldol Light. It's kind of got a lot of the same side effect profile as haloperidol. What is a commonly given combo of drugs given to agitated patients in the emergency department? This is called a B52, and you're going to hear about this a lot because B52s get given all the time. So it's Benadryl, it's IV Benadryl, 5 milligrams of Haldol, and 2 milligrams of Ativan. So this really knocks people out and is commonly given in the ED setting. What is the earliest extrapyramidal side effect of antipsychotics? that would be acute dystonia, hours. So basically you give it to them and then all of a sudden their neck is like craned like this and then they can't move anymore. That's acute dystonia, and that's how it's going to show up on your test. Then it's akathisia. So akathisia is going to be like, oh, they can't sit still. They got to get up and keep walking around. They feel really restless. That's akathisia. Over weeks, then you might develop some symptoms of Parkinsonism. So they start getting a tremor, they start getting slowed gait, things like that. And then finally, tardive dyskinesia over months, which is when their mouth starts making all these idiosyncratic movements and their tongue starts moving all over the place and they make these facial grimaces. That's tardive dyskinesia, which happens over months. And one important question is tardive dyskinesia reversible once you stop the antipsychotics? And the answer is no. So tardive dyskinesia is actually a permanent side effect of antipsychotics. What is a class of drugs used to decrease the extrapyramidal side effects of antipsychotics? That would be anticholinergics. Commonly, we see cogentin or benzodiazepine. And then in acute settings, you often see Benadryl used. And next, let's talk about some personality things. So there's a really bad kid who doesn't obey the rules, doesn't show up in class. He's being an asshole to people. That's called oppositional defiant disorder. And then next is the same thing as above, but also the really bad kid is violating the basic rights of others. They're stealing, they're exhibiting cruelty to animals. That's called conduct disorder. And this will definitely show up on your shelf exam to differentiate these two. So again, conduct disorder is basically a worse version of oppositional defiant disorder, where conduct disorder is where they're really violating the rights of other people and being cruel to animals and stuff like that. And then what is conduct disorder but age greater than 18? That is antisocial personality disorder. So you can't diagnose a 16-year-old with antisocial personality disorder because their personalities are still developing. You have to diagnose them with conduct disorder, and then if it's still continuing after the age of 18, then they're considered antisocial personality disorder after that. Next is early or late onset of schizophrenia favorable. This is something that'll probably show up on your board exam as well. And a late onset of schizophrenia is actually more favorable. And here's actually a little bit of a graphic that shows you some of the good prognostic and poor prognostic factors in schizophrenia. So you can see that good prognosis is associated with late age of onset, an obvious precipitating factor, acute onset, and good, supporting factors at home. And then poor prognosis is young onset, no precipitating factors, insidious, slow onset, and then they have really bad social support system at home. Now let's go over some of the antipsychotics. So now we have our first generation antipsychotics and we have our second generation antipsychotics. And it's really good to go on Google and just look up these charts that show you the different side effect profiles for each of the antipsychotics. So again, we have risperidone first, which is called Risperdal. Again, that's also known as Haldol Light. It does have the highest risk of hyperprolactinemia and the extrapyramidal effects that I talked about earlier. Remember, it's Haldol Light. Quetiapine, this one is called Seroquel, and this is one we commonly use in patients who have delirium or we want to help them sleep better at night. It's a lot more sedating than the other medication, so it's really good to give somebody right at bedtime, which is what we frequently do in the hospital. And you can kind of remember it as quetiapine, as you're trying to make them quiet. But this is actually a very commonly used one and a very effective one for hospital-induced delirium. Olanzapine, this is called Zyprexa, and this is a really, really useful one that we tend to use more for the acutely agitated patient. Remember, O means basically the O in olanzapine means they're going to get really fat and get a lot of weight gain. So you see weight gain is a huge side effect of olanzapine, but we use Zyprexa a lot and it's a very effective one. So just watch out for that weight gain with that. And then clozapine, again, this is Clozaril, and this is the most effective one, but it has the most scary side effects, most notably the agranulocytosis. So this is really just a last resort medication that we use. Aripiprazole, look at that side effect profile, really nice all across the board. This is called Abilify, and we do tend to use this quite a lot, but it's kind of limited in that I feel like it's not as strong or as effective as, Seroquel or Zyprexa, but it definitely is a good option, especially outpatient. And then we have ziprasidone. This is Geodon. I don't see it used quite as often because it's got BID dosing and it requires taking with food. So it can become a really big issue with patients who already have some difficulty being compliant. It can just worsen the chance that they go into a psychotic episode because they weren't taking it with food or they weren't able to take it twice a day. And then for typical antipsychotics, we have Haldol. Again, really just useful in just like the acutely agitated patient is where we most commonly see it. And then chlorpromazine is also known as Thorazine, I believe, and we don't really use it anymore. It's a very old school drug. It's got a ton of side effects. Now let's talk about the SSRIs. Again, go on Google Images and look at the different side effects and the half-lives of all these medications. Because I remember in psychiatry rotation, I didn't know when I should prescribe which SSRI or not. So really, I think the number one that we see the most often is sertraline or Zoloft. This is just like a really good one. It's got probably one of the better side effect profiles. So I would say sertraline is kind of your go-to in most cases. Obviously, it's institution dependent. So Paxil, this is a good one, but it's got a longer half-life and its side effect is sedation. All right, next we have fluoxetine, otherwise known as Prozac. And this one, the adverse effect really has a lot of drug-drug interactions. So this is one that I tend to avoid a little bit more. Not that I'm prescribing these all that frequently anyways. Citalopram is Celexa, another really good one. And for me, probably the number 2 one that I would use. Also, Lexapro is escitalopram. So basically, these are number 1 and number 2. They're pretty similar. So really, I think Zoloft is always a safe choice. Celexa, Paxil, you want to worry about sedation, especially in your elderly patients, because it can cause them to have increased risk of falls, stuff like that. Prozac, too many drug-drug interactions, so not quite as good. Venlafaxine, this is really good. This is called Effexor. And then you also have Cymbalta, which is duloxetine. Again, these just have the side effect profiles of the SNRIs, which tends to be what? It tends to be hypertension. But also, remember, it's really good for people with nerve pain. So these are actually used a lot in the hospital as well. And then you have mirtazapine. This one is associated with weight gain. But can actually be really useful because if you want somebody to gain some weight and you want to stimulate their appetite a little bit, you can give mirtazapine, and that's actually a really good choice for them. Now let's talk about the different classes of the benzodiazepines. So here's the big list. LOT, remember LOT are the ones that you can use with liver dysfunction. And then alprazolam, that's called Xanax. We see this a lot, but really we try and get people off of Xanax because it's very short acting. And so it doesn't really provide the best control of somebody's anxiety. It's just like a crutch for them to Band-Aid over their anxiety. And it leads to worse addictions and stuff. So I really don't like when patients are on Xanax. Chlordiazepoxide is a really long-acting one. I don't see it too frequently. Clonazepam is called Klonopin. Then we have Valium, which is diazepam. This is a really, really good one because it's got a super long half-life. Really good for alcohol withdrawal syndrome. Also really good for anxiety and just having a baseline control of people's anxiety. And then you have lorazepam, which is very frequently used in the hospital, and it's called Ativan. All right, now let's talk a little bit about alcohol withdrawal. What are some of the effects and the timing of these effects? So first, you start off with tremors, anxiety, and insomnia. And this happens over the first 24 hours of the last drink. And then within 24 to 48 hours, you get autonomic dysfunction and abnormal vitals. And then around 72 hours, this is when you get the risk of delirium tremens and seizures. So this is the really dangerous period for alcohol withdrawal. What is a treatment you should give to prevent Wernicke's encephalopathy? That would be thiamine and glucose. And of note, you should always give thiamine before you give glucose, because if you give glucose first, you may deplete their thiamine even more and then cause Wernicke's encephalopathy. What are the symptoms of Wernicke's encephalopathy? That would be CAN, or confusion, ataxia, and nystagmus. What is the structure of the brain that is damaged in Wernicke's encephalopathy? That would be the mammillary bodies. Now you have a patient with a history of alcohol use disorder who now makes up things and makes up stories as if they are fact and they truly believe that these are real stories. That's called Korsakoff syndrome. So that's basically Wernicke's encephalopathy, but now it's progressed to Korsakoff syndrome. Patient with a psychiatric condition now can't talk, and when you lift their arm, it stays there. And this is pretty crazy. I actually saw this on my rotation. This is called catatonia, and that finding of their arm staying there is called catalepsy, or what they call waxy flexibility. So literally my attending just put the person's arm here and it just stayed here and it just started slowly coming down, but it was just so weird. Patient falls asleep frequently during the day, and when they go to sleep, they hear their name being called. That is a question stem for triggering narcolepsy. And what are the terms for hallucinations seen in narcolepsy? Those are called hypnagogic and hypnopompic hallucinations. So hypnagogic hallucinations happen when you're going to sleep, and hypnopompic is when you're waking up from sleep. What is the term for falling asleep with strong emotion in narcolepsy? So on the question stem, they're going to have somebody who's like laughing at a party or something and then all of a sudden falls asleep. This is called cataplexy, not to be confused with catalepsy in catatonia. So cataplexy for narcolepsy and catalepsy for catatonia. As if that wasn't confusing enough already. All right, treatment for narcolepsy. Again, you're going to be using modafinil, and always, the SSRIs is always the right answer. So if they're having cataplexy, SSRIs are pretty good for that. Okay, so now a patient lost their job 1 month ago, and they have decreased sleep, concentration, and interest. This is called adjustment disorder. Notice again how I only included 3 out of the 7 Psychiatry caps or whatever. I didn't include 5+. Because there's a difference, and this is how they always are going to ask it on your board exam, is that they're going to have a patient who lost their job 1 month ago, but they have 5+ of the Psychiatry caps, and that's just called major depressive disorder. So again, if they are meeting some depressive symptoms, but not 5+, then it's adjustment disorder. If they have 5+ of those depressive symptoms, you just call it major depressive disorder. And then what is the difference between bereavement, complex grief, and major depressive disorder? So bereavement is normal function. This is normal grief. The patient feels very sad after a loved one passed away. Complex grief is they're feeling so bad that it's impairing their function, and their focus is really on the lost one. Like, oh, sometimes I wish I was dead because I could join the lost one in the afterlife or whatever like that. And this is in contrast to major depressive disorder, where there's impaired function, but they're focused on their self. So, oh, I wish I was dead because I hate myself and because I suck at everything and I feel guilty and I'm the worst. That's major depressive disorder. But then in the question stem, if they're focusing more on the lost one, like, oh, I want to be with the lost one, I'm like feeling like I want to die because I want to hang out with them, that's more complex grief. All right, just one other thing is that for the adjustment disorder, it has to be depressive symptoms within 3 months of onset of a stressor. Okay, so if it's past 3 months of the stressor, like they lost their job 4 months ago and they're having these symptoms, then you don't call it adjustment disorder. What do you call depressive symptoms up to 10 days after delivery? That is postpartum blues, and that is normal and very frequently seen. And then you have depressive symptoms lasting greater than 10 days after delivery. That's called postpartum depression. And a lot of times on UWorld or on your shelf exam, they're going to ask you, oh, what should you do to a patient who's feeling really depressed like 3 days after delivery? And the answer of that is most likely it's just going to self-resolve and it's postpartum blues. But if they give you a patient who's feeling depressed and it's been 15 days after delivery already, then it's telling you this is postpartum depression and they need treatment. They need like an SSRI, they need counseling, etc. What if you have a patient on antipsychotics who develops a fever to 105 and severe muscle rigidity? What is that? That is neuroleptic malignant syndrome. And what is the treatment for neuroleptic malignant syndrome? That would be dantrolene, removing the offending agent. And then if that's all not working, you can still try some dopamine agonists after that, like bromocriptine and amantadine. Is access to firearms an important aspect of the suicide risk assessment? That answer is yes. What are the top 2 risk factors for suicide? That would be a previous attempt or a first-degree family member with a completed attempt. And this is an important one that you'll probably get pimped on at some point. And then there's a couple of culture-specific psychoses. So this is not super high yield, but I just thought it was super interesting and it's just kind of fun. So a patient believes their penis is shrinking and will disappear, causing death. That's called choro. And then this one's cool. A sudden unprovoked outburst of violence of which the patient has no recollection, seen in Southeast Asia. That's called amok. So this is where that phrase, people are running amok, comes from. It's from this psychotic disorder that's seen in Southeast Asia. What is the reversal agent for benzodiazepine overdose? That would be flumazenil. The risk of flumazenil is, again, you get that lowered seizure threshold. And then here's an important one that I feel like comes up all the time on board exams. Step 1, Step 2, Step 3, your shelf exam. So definitely know this one, okay? This is a patient with a lot of anxiety about a bunch of random unconnected symptoms. And then you have a patient with a lot of anxiety about having one particular illness despite few or no symptoms. So what are those? That is somatic symptom disorder for this first patient. Like they're coming in, they have a cough, they got like some chest pain, they have abdominal pain, they have like a headache, they have some like vision changes, none of it like connects at all. That's somatic symptom disorder. And then patient with lots of anxiety about one particular illness, that's illness anxiety disorder. So this will be the patient whose family member got diagnosed with breast cancer, and this patient feels like they have breast cancer even though there's like no symptoms, and they're just always worried about breast cancer, and they have nothing to suggest that they have that. What is the appropriate next step for lithium overdose after gastric lavage? That would be emergent hemodialysis. This is part of that AEIOU mnemonic that you might know about. Acidosis, electrolytes, intoxication. So intoxication includes lithium. And then this is overload and uremia. Difference between diazepam and lorazepam, we kind of went over this already, but diazepam is really going to give you that longer acting half-life. What do you call PTSD but less than 1 month's duration? That's called acute stress disorder. What is a good duration to use an antidepressant after a patient's first major depressive disorder episode? That would be 6 months. If they are having recurrent episodes or severe episodes, like with a suicide attempt, then you would continue it indefinitely. But if somebody just comes in with their first episode of depression, you give them SSRI, they're feeling better, then after 6 months, it's reasonable to try to titrate them down and get them off the medicine and see if they actually do well without being on an antidepressant anymore. Patient who gets crazy angry and overacts disproportionately to small stressors. Think about patients who like have really bad road rage or something. That's called intermittent explosive disorder, which I just love the name of that. I don't think this is particularly high yield, but it might come up and you'll definitely read about it. But it just sounds like diarrhea, so I really like intermittent explosive disorder. Method of drug delivery for a non-adherent psychotic patient. This is somebody who's not compliant with their medications. They're not able to take it daily on their own. You can give them a depot, which is basically put something under their skin and it'll just slowly release this antipsychotic over time. And then if they're agitated and acutely need something, you give it to them intramuscularly. What is the most common side effect of SSRIs? That would be sexual dysfunction. This is actually one that I got wrong on New World. It's not nausea and vomiting, which is like usually the side effect that is like every medication side effect is nausea and vomiting. But for SSRIs, actually sexual dysfunction is more common than nausea and vomiting, apparently. And then what is the difference between malingering, factitious disorder, and Munchausen's disorder? So malingering is for secondary gain. So they are deliberately faking their symptoms because they get some kind of like monetary benefit or they get like some insurance thing. That would be malingering. And factitious disorder is the same as Munchausen's disorder. Munchausen's disorder is just the historical name for this. And that's primary gain. So this person is acting sick, but they're not deliberately doing it. They're just doing it to like fulfill the sick role and to try and get like treatment and have caretakers and stuff like that. They're not doing it for like some monetary reason or anything like that. All right, so that is my 6-question guide to psychiatry. Lots of pimp questions. I hope they're super useful for you guys. I hope it helps you on your shelf exams. I feel like a lot of these will be questions that might show up on your exam. I hope this was helpful. Hope you enjoyed, and smash that like button if you like this video. I'm going to be releasing the other guides shortly. Really enjoy making these for you guys. See you in the next video, and peace.